And you are live.
So, good morning to everyone. I'm Fabio Taccone from Brussels, and I have the pleasure to chair this debate session on the use of target temperature management with Catherine Burke, who is Associate Director of the Center of Resuscitation Science in Boston. Catherine.
Thank you, Fabio. Good morning, everyone. I'm Kate Berg. I'm an intensivist in Boston, in the United States. And so for our session today, we're going to have two speakers just summarize their perspectives on targeted temperature management, and then we'll follow that with some discussion from our panel and from all of you. And our first speaker today is Dr. Ben Abella, who's a professor of emergency medicine and vice chair of research at the University of Pennsylvania, and will be defending the temperature of 33. Good morning, Ben.
Good morning. It's good to be with everyone. And I want to first acknowledge and honor my debate partner. I'd rather not say opponent. I'd rather say partner, Dr. Hans Freiberg as well. So we'll be discussing, of course, one of the raging questions that continues in the field of post-arrest care, which is the appropriate target temperature. Maybe we can get my short slide deck. Many of you have seen our recorded slides, I believe, which would be great. We each have a 12-minute talk recorded on the session, but I'm now going to just go into a little 5-minute summary of that 12-minute talk. Francesca, if I could get the slides. I think you have the slide deck to share. Fantastic. So yeah, if you want, you could you could start there. That's fine. That's me. If you want to contact me, there's my Twitter handle. I'm certainly happy to keep this as an ongoing discussion. I'd love to correspond with some of you about this topic. Next slide. Yeah, so really the fundamental issue at hand, and the reason why this debate is in the program at all, is that there have been, of course, a number of clinical trials that have shown that targeted temperature management, or reducing the temperature after cardiac arrest, the global body temperature, has shown improvements in survival and neurologic outcome. And I show you here a summary of the Hack and Bernard studies from 2002 that fundamentally showed that when patients after out-of-hospital VFib arrest were randomized to an arm where they were cooled to 33 degrees Celsius, compared to, I don't like to call it normothermia, a non-controlled arm, a wild type arm, there was a big improvement in survival. But then, of course, came along the work of Dr. Freiberg and Nicholas Nielsen and others, the TTM trial of 2013, in which patients were randomized to 33 versus a controlled temperature arm of 36, and they found essentially no difference in outcomes, and these were indistinguishable. And this really set the stage for this whole debate. The fundamental question is, we have three very, very different results here. Well, two were similar and one was different. How do we reconcile this? And some investigators and some clinicians have said, well, we should manage patients at 36 if there's no additional benefit at 33. And others, and I'm in the other camp, have felt that there are many reasons why we might consider 33 to be a default temperature. And if you could advance the animations, I think I have something that will appear here. Yes. So it's important to note that also that the adverse events were very, very similar in both arms of all three trials. So this is to say, for those who might consider 36 to be preferred, it's not really clear what you're saving, what you're gaining. In other words, what adversity you're reducing. Shivering, bleeding, infection rates are all very, very similar, whether you manage patients at 33 or 36. And next animation should pop up if you could. Yep. And so I'm going to keep a little bit of a running score, and I do this in my longer version of the talk, that so far we have two trials that show 33 is better. And it's important to note, no trial has shown that 36 is better, just that 33 and 36 may be indistinguishable. And so that's a draw, if you like, in the soccer analogy, or a tie, as we say in the United States. Next slide. And I think importantly, there's a large body of preclinical evidence that show a dose effect of lowering body temperature. That is to say, the lower you reduce temperature, and this is in pig models and dog models and cardiomyocytes, and I show you a number of investigators. I should also, of course, be showing Bob Newmar on this. He's done a lot of work in the preclinical area around dosing of temperature. There's mechanistic evidence, laboratory mechanisms that suggest that reducing body temperature works. These studies have shown shown change in cytokines, change in injury patterns, change in neuronal cell death. So there's good reasons why, a good rationale why lowering body temperature to 33 or even perhaps lower might make sense. Next slide. And then the other really important piece of evidence here is there have now been 3 or 4 observational studies to come out after the TTM trial. This is one example from our friend and colleague Nicholas Johnson in Seattle, where hospitals switched to 36 based on the TTM trial, and then they just looked at what happened. And these are not randomized trials, of course, but I think they're an important and valuable piece of evidence of real-world experience. And in this study, like several like it, this hospital switched to 36 and they found that outcomes worsened. So in the real world, switching from 33 to 36 caused worse outcomes, more neurologic injury, and more death. So if you can click the animation. So now we have 2 studies showing 33 is better, 1 draw. The preclinical evidence clearly shows 33 is better. And in the real world experience, 33 appears to be better. In now, as I say, 3 or 4, depending how you add them up, observational studies, several in Europe, 1 in Australia, and 1 in the United States. Next slide. And then, of course, you have the Hyperion trial that came out more recently. That was a large, very ambitious study in France done in 25 ICUs. Next slide. And I'll be finishing up in 60 seconds here. And next animation. And what they showed is that there was an improvement in neurologic recovery. Now, granted, it's a small number of survivors, but a pretty dramatic improvement, almost a doubling in CPC 1-2 outcomes with 33 versus 37. Now, in many ways, it's unfortunate that the Hyperion trial didn't randomize to 33 versus 36, because then we could do a more proper head-to-head comparison with the TTM trial. Nonetheless, this study also supported that 33 improved outcomes. And next animation, if you could. So now we have 3 studies that show 33 has improved outcomes, none that show that 36 is better, 1 tie, and the preclinical and real-world evidence both support 33. Next slide. Now, lest I be a little unfair and say that I endorse 33 for all cases, I think the camp that Dr. Freiberg is going to be arguing has some merit, and probably the most important clue, the most important study to come out in the last 6 to 12 months on this was from Cliff Calloway and others in Pittsburgh. And next animation, if you could. In this study out of Pittsburgh, they looked at an observational cohort, a very large observational cohort, really, in the post-arrest space, where patients were just treated at 33 or 36 for a variety of reasons. Now, of course, there's selection bias here, but they did a number of statistical adjustments to try to look at that. And they looked at injury severity. So in Pittsburgh, they ranked patients' injury from 1 to 4. And what they fundamentally found, and without looking at the odds ratios, I'll just show you graphically at the bottom, next animation. What they found was if patients had lesser degrees of injury, very mild post-arrest injury, 36 actually may have given them a better outcome. Now, granted, retrospective data, so we have to interpret with caution. But then next animation, the patients who had more significant injury, 33 was linked to a better outcome. And so really, it's not so much that I disagree that 36 or 33 is better or worse, but rather I think fundamentally we're going to reach a point, and this is probably where we should have been heading for years, that we should be tailoring patient care, and that specific patients might do better with specific therapy. And that, in my belief, 33 is probably appropriate for most patients. And I speak from a US perspective where we largely see very, very injured patients, less bystander CPR, longer response times. But it may be true that for patients with more mild injury, 36 may be better and that it may avoid some of the adverse effects. And with that, I'll stop.
Great. Thank you, Ben, for that excellent summary. And before we go to our next speaker, I wanted to just call people's attention to the live poll question, which is, what is your approach for temperature management in comatose patients? You might now be biased a little bit by Ben's presentation, but so feel free to answer that if you haven't already. And on to you, Fabio.
Thanks. You're right. We should have said that we had 2 pool questions. One is about your practice. I think there are now, I see 12 responders. I don't know if there are more. I will check
we
it.
have 70 so far. So
70. So maybe we can disclose the results, because we have a second pool question after Hans Freiberg. So at the moment, which is your approach, we have 36 degrees, 50% almost, 30% is 33 degrees, just avoiding fever, 22%, and 1% is TTM, another temperature target. As I said yesterday, we have 22% of people do not follow the guidelines, which is interesting, but it's okay. So now it's my pleasure to introduce the second speaker. Is Hans Friedberg, professor of anesthesiology intensive care at Lund University and the senior author of the TTM study. Hans, the audience is yours. Just try to debate what Ben had just presented. Thanks.
Thank you, Mr. Chairman, Mrs. Chairman, and thanks a lot, Dr. Benabella, for this balanced report and pro stance. I would like to have my PowerPoint slides presented, please, on the screen. That's my last slide. The first one, please. Very good. So what is the optimal temperature during stress or after cardiac arrest? Next. The fact is that we do not know. So that's why I stress that we should stay with the guidelines. That's the best we can do. And I'm fine with 32 to 36. Either temperature is fine, according to the evidence we have today. Personally, and in many sites in our country, we have changed to 36 and we stay with 36. But we strictly adhere to our protocols and we avoid fever also for 72 hours following the intervention. So in search for the optimal temperature, next, there are many questions to be answered. Still, there is the issue of deeper TTM, prolonged TTM, or a combination of the two. Next. The timing of TTM, personally, I find of most importance and should be evaluated further in experimental settings. Next. Individualized care, as Dr. Abella mentioned, is probably of importance because one size may not fit every patient. Next. But the overall question, of course, that we need to answer is whether TTM after cardiac arrest matters at all. Next. There are many questions that remain. So the translation from experimental setting to the clinic and back, there are many unanswered questions. Next. Because rodents and humans are not the same. Most studies have been performed on small size animals, rats and mice, very few on larger animals like pigs and dogs. Next. And this is something we looked through in a systematic review and meta-analysis by Ulai et al. Published in Intensive Care Medicine Experimental recently. So we need to go back to the lab to answer the relevant questions. And the relevant questions include that we use the relevant species. Large animals, pigs. Dogs are no longer possible, but definitely pigs. We also have to look at comorbid animals to make it more equal to the human setting. And also we have to look at clinically relevant delays. So lots of questions that yet have to be answered, and we have to answer them in the lab. That's my argument. Next. In the meantime, we will have to do the relevant clinical trials. The TTM2 trial is one such large trial where we compare hypothermia to 33 compared to early treatment of fever. Fever defined as 37.8 Celsius. Next. And the next. So we have finished inclusion to the TTM2 trial in January of this year, and we will soon have the results, and the results will be presented as it looks now in March of next year, probably during a web conference. So depending on the results, what will we do with them and how will we interpret them? Well, one option is that there may be a benefit of 33. If so, I think many of us may consider moving to 33 or staying at 36 based on the results from the TTM trial. And that the next trial would be to investigate and look at the duration and what the optimal dose of TTM might be. Next. The other option is that the results show a benefit of strict normothermia or that it's clearly neutral. And if so, I believe that many would abandon 33 as an intervention temperature and stay with whatever temperature target they have today, like 36, or at least avoiding fever. And if this is the case, if these are the results, we must look at the role of fever and investigate the role of fever in the next large trial. Next. Personally, I think we must also look at ultra early hypothermia in dedicated centers. This should also be done in the experimental setting and be compared to clinically relevant delays. Next. So in conclusion, I argue that we wait and see with regards to TTM after cardiac arrest. Next. For what? Well, next. We should wait for the results of the large TTM2 trial, 1,900 patients, more patients than all the other trials combined. We should also really try to go back to the lab and look at the results of relevant animal experiments. And these still have to be done because most animal experiments have not been performed in relevant animals with clinically relevant delays, etc. Next. And in the meantime, I think we should stay with TTM 36 degrees Celsius or a TTM strategy that you are comfortable with. Next. And with that, I thank you very much.
Thanks a lot, Hans. Very clear presentation. I just want to remind, because before I give the word to Catherine, just to remind you that now we should maybe launch the second polling questions to see whether you have changed your mind according to the two presentations in terms of TTM strategy. And now maybe I can leave Catherine introduce our panel that will debate about the use of TTM according to their view, and then we'll also have the place for Q&A during the debate.
Sure. So we're very happy to be joined by three expert panelists. So Dr. Sarah Perman is an emergency medicine physician from Colorado in the United States, just a cardiac arrest researcher as well. Dr. Bob Newmar from Michigan in the United States, also emergency medicine and co-chair of ILCOR. And then Dr. Tobias Kronberg, who is a neurologist from Lund and also expert on neurologic recovery and TTM. So thank you all for joining us. I think I am starting to see some questions come in quite quickly on the Q&A, but I think first we just wanted to get from each of the panelists your personal approach and kind of why you have taken that approach, just in a couple of minutes, and then we can get the discussion started. So Sarah, I don't know if you want to start.
Sure. Thanks so much for those two incredible presentations. It's always wonderful to hear from the experts and leaders in the field and hear their perspectives. So I appreciate that. I think this is a struggle. This is a struggle that we encounter frequently at our own institution. And anytime there's protocol changes, there's always questions and concerns about how to approach this. And so I especially appreciated Dr. Freiberg's comment about it's important to pick something and do what you're comfortable with, because I think that what we've seen with this protocol is our success is based on the protocolization and how people approach this from a clinical perspective. But I will say, the way that I've thought about this is maybe a little comparable to my US colleagues, which is while I admire the TTM trial and the patients who are enrolled in that study, sometimes I fear that the patients that I see in the emergency department in Denver, Colorado, don't always look like that patient population. And so, I think we tend to take an approach where we We look at the patient population that we see, which potentially could be a little bit more injured than the patients that were randomized in the TTM trial. We tend to take an approach that fortunately, we've found that there's no adverse event difference between 33 and 36, and having that data is very important. And so we do like to approach, and I do like to approach 33 if that seems like a good alternative, because we do see a high proportion of patients who have non-shockable initial arrests, prolonged downtimes, poor rates of bystander CPR, high incidence of shock, return of spontaneous circulation. So we do approach the patient in that sense. I will also say having 36 degrees Celsius as an option is fabulous, because we don't see patients now who don't get any therapy, which I think historically we did see patients who unfortunately might not fall into a category where 33 was an option. And so instead they got very little management from a temperature perspective. And so I think having 36 as an option is tremendous. But, I think as a group, we're looking at the data and will respond accordingly and eagerly await the results of some of these new trials that are coming down the pike. So thanks.
Great, thanks, Sarah. Let's see, Tobias, do you want to give your perspective, your practice?
Thank you, Kate. Yes, I'm on Hans' team here, so I could just cite Hans that we stick with 36 after the TTM2 trial enrollment is finished, and we wait for the results, of course. But I just wanted to comment a little bit about what Ben was discussing, the evidence from the experimental side. And I think there is overwhelming evidence that there is an graded effect of hypothermia, and that lower is better in the experimental setting. I think it's very puzzling that we didn't see any effect at all, or any difference between 33 and 36 in the TTM trial. And I think that my interpretation is that probably the patients that we enrolled in the TTM trial are very different from the animals and the animal setting. Otherwise, we would have seen a graded effect and a difference between the two temperatures, because there's such a wide difference between 33 and 36. And I think I agree with Hans. We need to go back to the experimental setting. We need to do a lot more research to try to find the window of opportunity for temperature management. And probably we need to start a lot earlier and get the humans cooled a lot faster if we would have any effect. That's my personal opinion here.
Great, thank you. Bob, I'll turn to you for our last panelist opinion. What do you think?
Thank you, and it's just an honor to be part of this panel and this important discussion. I guess my first disclaimer is all my opinions viewed here do not represent that of ILCOR, in that I'm an ILCOR co-chair. So I'm going to just give that disclaimer first of all. Second of all is I am a laboratory scientist who have done significant amount of research in therapeutic hypothermia for cardiac arrest. So I think I am biased in some ways to having seen the results of work in my own laboratory, the benefits of hypothermia. But I do think when we do our clinical practice and there's any level of uncertainty, we need to really have a balance between what we know about pathophysiologic mechanisms, what the preclinical data tells us, and what the clinical data tells us, because they all have limitations and we need to find a balance between those. So based on that, my practice is to cool at 33. And I think the reasons for that are, one, there is no pathophysiologic rationale or mechanism by which 36 would be better than 33. So it didn't make sense to change from 33 to 36. There's really no animal data to support a target temperature of 36 rather than 33. And I think that, with the TTM trial, the one concern I have is the potential that the optimal therapeutic window or optimal application of the therapy might have been missed. So if we look at any therapy, there's a therapeutic window, and the time to target temperature for therapeutic hypothermia is likely to be an important parameter by which the therapy is effective. And the longer it takes to get to target temperature, I think the less treatment effect will be able to be detected. And at least in our animal studies, we found that if you delay achieving target temperature somewhere between 4 and 8 hours, the treatment effect is lost in animal studies. So that could be a potential mechanism by which there wasn't a detection of a difference in outcome between 33 and 36 in the TTM trial. I guess I'll stop there and wait for additional questions.
Thanks a lot.
If I could make a comment, so I think Tobias makes a really important point about the discrepancy, the differences between the laboratory and the clinical setting. I think it's important to point out to the audience, just a general point. This is seen in so many fields of medicine, where we've cured cancer in mice a million times, and then those therapies just don't work in the humans. And so this is not specific to our field or specific to post-arrest care, but rather I think speaks to a point that I think Hans is quite correct about, which is that models have to be relevant. The models have to reflect the clinical situation. And for example, many of the animal models are on perfectly healthy young animals, as opposed to humans who have cardiac arrest in their 60s or 50s, 60s and have comorbidities and so forth. The other point to make about that discrepancy is that cardiac arrest, as we all know, is very variable. People have variable injuries and variable downtimes and so forth. So it's not too surprising, perhaps, that we might not see the same differences. But I think the fundamental point is that I for one don't see a mechanistic reason why 36 would be better. So while the animal literature has to be interpreted with caution, I think looking at mechanisms of disease and the pathophysiology is still important. But
Hans, do you want to close the loop? Have a last word?
No, I think it's reasonable, and I have no problems with the. I'm a kind guy. I have no problems with folks who treat at 33 or 32 even. So I really find the recommendations from the ILCOR and ERC and AHA as balanced and very good. I mean, it reflects the present level of evidence, but we need to know more and better, and we need to do the relevant trials. And I really see a strong need to go back to the lab, because we will not be able to answer the questions even in large trials. We don't have the results from the TTM2 trial, and we may not have the answers we want after we have the results. So back to the lab, large animals, relevant delays, preferably comorbid animals.
Maybe Catherine, if I can start with the question from the participant. I will start from our panel. So there is a very interesting question from Federico Semeraro from Italy, that I know very well, very nice guy. He said, 33 and 36 is like a religion. The problem was the science communication. Many have dropped out of the TTM after TTM1. So I think the question is, and Hans would agree, TTM had never said, don't do anything. They just tried to investigate 2 different doses of temperature. So my question is, do you think that what we see in the real world studies is more than people use an inappropriate protocol of TTM and they say we do 36, but basically they just avoid fever? Is it probably that you don't stick to the protocol anymore because it seems that 36 a little bit loose temperature target, they don't care anymore to this?
I definitely think so. People don't adhere to protocols anymore if they see these results. The TTM1 trial was perfectly controlled. We have all the different variables that we have looked into. There is not a single variable or an outcome measure where we see that 33 or 36 is better. They are very much similar. So, and there are conflicting results with regards to these observation studies too. There are those studies showing benefit of 33, sticking to protocol at 33. There are those showing benefit of staying at 36. I think the problem is whether you adhere and stick to the protocol or not.
Yeah, I guess the only thing I would add there, though, is that if you have to in the real world accept a range of temperatures outside your target, for example, if you're going to be 2 degrees above or below your target temperature just in the real world application, then a target of 33 keeps you in the therapeutic zone a much larger percent of time than a target of 36.
But there is really no reason, Bob, to not be in the target range, because patients, as you know, are like 35, 35.5. We have plenty of time. Usually we have hours to prepare for a TTM intervention. So we shouldn't allow, we certainly do not allow patients to go above 36. But this may be the case. You're right. It may be the case.
Yeah, and I think it sort of is Bob's point is not so much that patients come in already at 35, so attaining 36 initially is hard, but rather there's just in the real world natural variation. You know, maybe cooling systems are less well controlled. Maybe a patient has to go to the CAT scanner and they disconnect the system for a little while. Maybe there's other conflicting things. And so if you're at 36, there's just sort of less room for error. You know, there's less room for variable clinical care. And I think one of the fundamental things we all have to be aware of is none of us live in the world of perfect randomized trials. And the real world care is enormously variable. I am constantly struck when I interact with hospitals in the community in the United States, the enormous variability in experience and knowledge and understanding of this therapy. And so I would also make a pitch for all of us that whether we pick 33 or 36, education and training of clinical teams in what the trials mean, in how to apply them, is something we need to do. I mean, it's the real challenge. I think we have a major implementation challenge. Never mind the question of target temperature. We need to make sure our clinicians understand the importance of these therapies and how to apply them.
I agree, Ben.
I think to follow up on that too, one of the comments that I like to share is if, you know, irrespective of what temperature you pick, whichever one you pick, just do it well. Because I think we do see a lot of that considerable variation, and some of it's based on different interpretation of the data. You know, I think we do frequently see this situation where patients have a core temperature of 35.5, and so the premises will leave them be. And that, again, you know, referencing back to the literature, that's not targeted temperature management. So I think that's a struggle. And I think, as Ben alluded to in some of his slides, the real world experience is incredibly variable. You know, I've heard things like, you know, we can use less paralytic insedation if we go to a 36 degrees Celsius as opposed to 33. And, you know, I think we've all seen huge temperature fluctuations in those patients. And so I think the premise really is, you know, if while we're trying to figure all of this out and figure out which is the better temperature, which is the appropriate temperature, and should it be tailored to the patient, you know, it's very important to encourage people to do the therapy well, irrespective of the temperature you pick.
I just wanted to another comment as well, because I think with the introduction of hypothermia, we got a treatment for this category of patients, and that was a huge difference. We didn't have any treatment that we believed in before, and now we have it. And I think that if we sort of move away from having high targeted temperature management as a treatment that we believe in, then we will kind of invest less in the patients. And we know that the mortality is very high in these patients, and they die because we withdraw intensive care. We make a decision, and that decision is made with a lot of prognostication, but it's also a lot of subjective power in that decisions. So I think just believing or not believing will have an effect. And I think we saw some of that effect in the early trials of hypothermia as well, because they didn't have blinded prognostication.
I have a comment to that also. I really think so too. And our strategy has actually not changed much at all. We care for the patients in the exact same way as we did when we cooled to 33. That is, we sedate, we paralyze when needed, we initiate TTM with a device. The only difference is that we have more time. So in my world, we would have more time close to target temperature with a 36 strategy if you follow that advice. Do everything like you did before, but just set the target at 36 instead of 33, and you will have the same results. That's simplifying, actually, care of the patients. But I agree. One problem may be that you choose not to activate the device because it's an economic issue. That's a bad solution. I think a good solution is to keep the care as you did. Just change the target temperature.
This is a great discussion. I think we have a lot of questions that have come in from the participants, so I'm going to try and get to some more of those. There are a couple of sort of related questions. So one is from Isfan Khalid and says, it's aimed at you, Ben, but I think would take input from anybody. Very informative presentation. Thank you for sharing all the studies, answers a lot of questions. What goes into tailoring temperature? And then another related comment and question from Rudolf Koster says, tailored therapy seems attractive, but it makes protocols more complex. And do we really know what factors we should be tailoring based on?
Yeah, those are a great set of questions. And I think that prompts me to say the last slide I had with tailoring therapy is a hypothesis. It's not a recommendation. The Callaway study published this year was provocative. It's interesting, but it's retrospective data that had a lot of statistical adjustment involved. So I believe in my heart that tailoring therapy is probably going to be best. I do not believe we have the evidence right now to do so. We don't know to what target, as perhaps the questioners point out, we don't know what to target. Severe injury versus mild injury, we don't even have the best real-time markers to assess that or to accurately measure that. So this is something that's been talked about for quite some time in our field, but we haven't quite gotten there yet, which is we really would love to have some objective biologic markers or endpoints by which to guide the tailoring of care. And we just don't have them currently. So, and I definitely agree with the question that tailoring will create a lot of complexity. And we're already struggling just to do this in the first place. So to add this layer of, oh, for this set of patients, it is that, I think tailoring is the goal, but we're not there yet.
I can comment on that. I think probably the most feasible strategy for individualized therapy moving forward will be related to duration of therapy. Because I think that's where there's animal data to suggest that duration of therapy will also have an impact, at least on neurodegeneration. And there might be mechanisms by which there's not the best mechanism right now, but if you can monitor in real time ongoing brain injury mechanisms and then monitor the response to therapy, you may be able to make decisions about whether to continue therapy for a longer period of time based on, could be related to EEG and seizures, it could be related to biomarkers, or even just clinical response. So there might be, I think that's probably the best opportunity for individualized therapy related to individualized duration.
And there are actually a couple of questions in here about duration as well. I think as Sarah was also trying to say about the tailored therapy question, I think in my center, there are, I think, like patients who are in a significant amount of shock, for example, and the clinical team might be reluctant to do 33 in those patients. And so we often will get people to do 36 in that scenario because I think they're more comfortable with it. I don't know, again, it doesn't really seem like the evidence is borne out that hemodynamic compromise is significantly different with 33 versus 36, but that's one way, and we would sort of a practical way that we do tailored therapy. Any other comments on that question? Otherwise, Fabio, you can pick up the next one if you want.
Yeah, I think there are, I'm on. Well, there are some questions that I find interesting because Hans alluded to some aspect of TTM. We discussed the dose, and of course, Jen discussed the duration. Someone said, if cooling at 33, does the rate of cooling have any effect? So my question for the audience is, all the aspects of TTM are interesting, but I found it a bit artificial to separate a study only on fast cooling, then only on dose, then only on duration. Should we try to optimize everything and then study this best optimal TTM compared to another strategy? So should we try to make the best effective cooling strategies according to the maybe animal literature in one study rather than just looking only one aspect? Maybe Sarah want to comment.
Sure. I think that's a great question. You know, there's been a lot of discussion even about, you know, rates of rewarming, because we you know, have kind of an interval time where we say, well, we should be rewarming at 0.25 to 0.5 degrees Celsius per hour. But I think, you know, there's been conversation if that's appropriate. And, you know, I think this raises the question that there's, you know, this is not a therapy that's a single dose drug, or you know, it's a prolonged therapy. It's, you know, potentially, if we include our neuroprognostication, it's upwards of 5 to 7 days. And so I think there's a lot of intervals in post-arrest treatment and post-arrest care that we need to think about. We need to think about actively, because I think, you know, there's been a lot of adoption without breaking those things down. So, you know, I would totally agree with the question. You know, should we be doing this? Probably. But I think, you know, there's so many questions, which I think is what's so exciting about this therapy is all of these questions, and fine tuning and figuring out what is the best alternative, and what is the best alternative for each patient is a really dynamic field.
I can comment, if I may.
Works.
So again, I mean, there are so many unanswered questions. We all agree on that. And it's cumbersome and costly to do clinical trials. We can do them. That's the good thing. We have networks today. We have collaborations. So we can perform large clinical trials, and that will be necessary. But I think it would be a waste not to go back to the animal labs and do these, test these hypotheses in large animals. That is a relevant model with relevant outcome measures. I would say at least 1 week follow-up in a pig ICU, test neurological outcome daily, and look at histopathology after 1 week or later. Probably later if we can do it. These are also cumbersome and costly experiments, but to a much lesser degree than trying at random in human trials.
So
Tobias?
a couple of comments on that. One is that there is an ongoing study, the IceCap trial, that's looking at temperature duration. It's an adaptive clinical trial design, initially comparing 12, 24, and 48 hours of cooling, which will adapt to longer or shorter durations depending on real-time analysis of the data. In that study, though, to be enrolled, you have to be at target temperature below 34 within 4 hours of cardiac arrest onset. So they have used a criteria for enrollment that at least is what's, you know, even 4 hours is challenging, but at least it controls for any delays in cooling that might be a confounder in that study. I will say to Hans's point, again, I do a lot of animal work. The problem with doing large animal studies is that to get long-term survival and long-term outcome, you have to use a relatively mild cardiac arrest model that only studies a subpopulation of the cardiac arrest population that we treat, and it's the least injured population of cardiac arrest that we treat. So the biggest confounder is that, you know, to get a severe enough injury in a large animal model, then you do have to have, you know, 3 or 4 day ICU. And even there's ethical issues related to surviving those animals longer if they're significantly brain injured. So yes, theoretically, having large animal models that replicate the human condition it would be ideal, but I think it's very challenging and very costly. Actually costs more than doing clinical trials. So it's hard to get the funding to support, especially if you're going to do dose response studies or therapeutic window studies, the cost becomes prohibitive.
Sorry, Tobias, you want to comment?
Yeah, brief comment. I agree that we need more animal data, and but I also, just like Bob said, I see the enormous problems with the costs of these large studies of large animals, and also some ethical issues, of course, with the survival of the animals and the problems with that. But still, I think, I mean, we are experimenting with humans instead. So I think certainly we need to argue to be able to get the funding together to do those studies as international collaborations in the same blinded fashion that we do the clinical trial, with the same high standard, scientific standard, to get a proof of concept before we move to humans. I think that's fundamental.
All right, thanks for all those comments. We have a couple of questions from the participants about pre-hospital cooling. So one question basically asking if you could start cooling patients, at the time of the event pre-hospital, and another one asking what information the Princess trial gives us and how you interpret those results. So let's see, maybe Ben.
Yeah. So for those who on this session who aren't aware, just a brief little overview. So the Prince and Princess trial are both trials that I encourage all of our audience members to check out. Really interesting and provocative work out of Europe, using a transnasal cooling device that allows for very rapid cooling, and indeed cooling during CPR, cooling before resuscitation, which is pretty exciting to think about. The animal literature is small on this, but fairly consistent that if you cool animals before, or cardiomyocytes in tissue culture, before you reperfuse them, you have much better outcomes. So, cold reperfusion, if you will, is a thing. And, that really hadn't been tried in humans because it's really difficult. But this transnasal cooling device, full disclosure, I have no association with that company and they don't pay me to say this. It's an exciting opportunity, I think. Now, the trials did not definitively show that transnasal cooling improved outcomes, but they were both suggestive, and there have been a number of sub-analyses published that have suggested that there may be some validity to this approach. Clearly, it's early. Clearly, we need more studies. But if the animal studies on this are to be believed, if you get cooling done really rapidly, and Hans alluded to this in his talk, I think used the word hyper early, or I forget the term Hans used. But if we cool very rapidly, it may be a different story altogether. There may be some very early biologic mechanisms that kick in within minutes of resuscitation that we may affect. Now, again, I'm stating a hypothesis. This is not well proven, but certainly the animal data are suggestive. And I would love to see larger randomized trials with this device or other similar ultra-fast cooling devices. Really hard to do, expensive to do, but I think needs to be done.
Hans?
Yeah, Hans, I know you have to leave us a few minutes early, so if you want to give your perspective.
I can quickly comment. Yes, I mean, there have been studies performed in Pittsburgh in the 90s. And as I recall, they quit those studies on dogs. They concluded that the therapeutic window in dogs was 15 minutes. If you delayed cooling more than 15 minutes, there was no more a therapeutic window. There was no effect of cooling. Now, there are more recent studies, pig studies from China, that tell a somewhat different story. So I would say we don't have the answer, but we need to look at this ultra early cooling strategy in large animals. I find it of great interest and importance to do it. And I would be happy to do this as part of a multi-center trial, actually, in pigs.
Just one comment on the study that Hans referred to. It's first author was Kubayama, and the issue with that study is that they only cooled for 1 hour. So it was a very short duration of cooling, which is very different from what we do, cooling for 12 to 24 hours. But it does provide evidence that there may be two, and we've proposed this theory, two separate mechanisms by which therapeutic hypothermia is neuroprotective. One that has a very short therapeutic window related to initial calcium overload in the neurons and mitochondria that comes, and free radical production that comes and goes within, maybe 15 minutes of reperfusion. And then the second, more prolonged mechanisms which therapeutic hypothermia may work. So adding those two together, having temperature cooled at the moment of reperfusion and then sustaining prolonged therapeutic hypothermia at least in our laboratory studies, has shown to be very synergistic and results in the maximum neuroprotection.
Yeah.
Now, the challenge is, even with the intranasal cooling device with the perfluorocarbons, even with that, it's a very, lowering brain temperature during CPR is not nearly as effective as lowering brain temperature when you have normal blood flow to the brain, because it relies on circulating blood to the brain. So if you don't have good brain blood flow during CPR, the effectiveness of that cooling strategy is a little bit limited, but you do get cooling much more rapidly at ROSC, but it may not be soon enough. And that might be some of the limiting benefits of that particular strategy.
Yeah, thanks, Bob. Thanks for that clarification regarding the studies, the dog studies from the 90s. It's a mystery to me that no one has pursued that question. I think that needs to be done. I'm sorry, I need to leave you. Thanks for this. Thanks, Ben. And thanks to the chairs and everyone.
Thank you.
Hans. Thanks, Hans.
Thanks.
So maybe I can take the next question. There are a couple of questions about how you basically provide TTM to the patient. So everyone has discussed the different aspects. We want to stick to the protocol. I am happy not to respond because I have conflict of interest. Do you think that the methods to induce TTM is an important issue or not?
And I'm happy to throw out a comment on that. Now, full disclosure, because I'm always a big believer in transparency, I have received consulting money from the maker of one of the devices, so that's important for everyone to hear. So in our hospital, we use the device that Arctic Sun by Becton Dixon. But honestly, I personally believe that the device does not matter so much, at least based on the level of evidence we have currently. Or rather, I should say this, whether there's subtle differences in outcome based on the device, and if one device is better, I think they are lost in the huge noise of the signal based on application and duration and other patient factors. So maybe in the truth, the device might contribute 1 or 2% to outcome, and 98% are based on other factors. So based on that, I think the one thing that's certain is that people should manage temperature with a closed loop system. So be it a catheter-based system or surface cooling system, I honestly don't think, again, just my opinion, that it has a profound impact on outcomes, but I do believe you have to have a controlled system. I just don't think we as humans, and especially clinicians at the bedside with all of our competing needs and priorities of patient care, can manage temperature with an uncontrolled system where we have to, it got too cold, change it a little bit, got too warm, change it a little bit. I think you need a closed loop system.
Sarah, you want to comment?
Yeah, so I'll put kind of my implementation hat on a little bit here, because I do think right now, I don't think we have the data to say that one is necessarily better than the other. But what I do think we know is that there's a lot of variability in the application of the therapies, and there's variability in our health systems. And so I think it's incredibly important until we know if there is a difference, or if one is potentially outperforms the other. I think it's important for us to think about our health systems and how they approach TTM. And some protocols are very nursing driven, and some protocols are a little bit more physician driven. And I think that can kind of help to navigate device selection as well, because clearly intravascular devices require a little bit more of a trained operator, whereas surface devices can be driven by nursing care. So I think there's the science side of it, which is definitely asking the question of if one is potentially better than the other. But I think there's also the implementation and the actual kind of practical side about what might work best in your institution to allow for immediate initiation and more rapid time to target temperature based on when you can actually start therapy.
Yeah, I mean, I would echo that. I think our decision to do surface cooling was really based on the practicality of time to initiating therapy. Even though intravascular cooling cools more rapidly, the time to initiation therapy is driven by the fact that surface cooling is an order that nurses can implement, and intravascular cooling is a procedure that a physician has to be available to perform. And at least in the emergency department setting where we try to initiate our cooling, we found that significant delays occur if you need a physician at the bedside to perform the procedure in the setting of an emergency department where there are many other things the physician needs to be doing. So we found that we can initiate cooling sooner with a surface cooling strategy, even though the cooling rate might be slower.
And we found the exact same thing. Our decision to go with surface cooling was because we saw big delays with catheter placement. Now, that said, those of you out there, if you can get that catheter slammed in quickly and get cooling going, a catheter-based solution, I applaud you. I think it's terrific, and you should go forth. We just were not capable of pulling that off.
Tobias, you want to add something on that issue or methods?
Well, I don't do cooling since I'm a neurologist, but I could only agree with Ben's last comment here. I think if you have a catheter from the experimental side, it's cool as fast as possible, certainly to get the best effect. And if you could get the catheter in very fast, that's bound to be the best option. But if you don't have those possibilities, and it will range a lot between patients, you should go for the surface. Yeah, that's how I would reason as well. We do both catheter and surface cooling at our institution.
And I think in a related question, it goes slightly back to the pre-hospital cooling issue as well. Because somebody had asked about if you're going to cool pre-hospital, what method would you use? And I know ILCOR has previously recommended against using iced fluids for pre-hospital cooling because there was some increase in adverse events. And I don't think, Bob, if I remember correctly, I don't think we've changed that recently, but I guess in your systems, do your EMS systems they start cooling patients pre-hospital? And if so, what method do they use?
We do not. Yeah, I think the bigger problem with the cold saline is that it, in addition to the potential detrimental effects in patients with, arrest because of congestive heart failure or who have heart failure as a result after ROSC, it's not a very effective cooling mechanism alone. So if you're just giving cold saline and doing nothing else, even in the studies, the temperature difference on arrival was very small. And so I think the early cooling is likely to be beneficial, but I don't think using cold saline alone is adequate to achieve what a therapeutic benefit.
I could just comment that if you believe in 36 and you live in Scandinavia, then pre-hospital cooling is not really an issue, at least not in the most periods of the year, because patients are at 36 when they arrive in median. So you don't need to cool them further.
So maybe I will leave Kate make the last question just to disclose in 30 seconds the results of the pool. So most of the people will stick to 36 on 33 as they did before. We have converted, like in the religion, most of people who did nothing to a new strategy, whatever 33 or 36. But there is a number of people who change from 33 to 36 or 36 to 33, and the number is equal. So it's an equal debate we have from Ben and Hans. Now we'll have maybe Kate, the very last question before closing.
Sure. So there was a question from Jazz Soar, which is, what do you think TTM3 should look at? So we just have a couple minutes. If you each have one thing you think should be in the next big trial.
I would say intra-arrest cooling.
Okay.
I would agree. I think we need to take the lessons from Prince and Princess and some of the weaknesses in those inherent in those designs and try to make a better, bigger thing. Now, this will require resources, energy, collaboration, all those hard things. But I think intra-arrest cooling, and maybe, by the way, also for intra-arrest cooling during in-hospital arrest. I think the in-hospital arrest population is understudied, and I know the reasons why. They're complicated. Many of them have a lot of issues that are pathophysiologically difficult. Nonetheless, there's a lot of advantages because the in-hospital or at least emergency room setting is a controlled laboratory. It's really hard to understand what we're doing in the pre-hospital world in EMS. The data are difficult to interpret. In the hospital, we can have coordinators, we have monitors. So it's the closest we have to the lab. And so I think studying in-hospital arrest for select patient groups may be of value as well.
Sarah, any closing study ideas?
Oh, that's a tough one. There's so many really interesting opportunities. I might, while I like the inter-arrest question, I might gear a little bit later on in the course of therapy, because I think really kind of creating a very good neuroprognostic strategy that's been trialed and vetted would be a tremendous opportunity. I struggle sometimes, and as we mentioned, there's so many patients in these cohorts who have withdrawal of life-sustaining therapy, and so I often struggle thinking about how we interpret these amazing new interventions when our outcome is a little bit challenging to interpret at times. So I would maybe encourage TTM3 to be at the tail end of our intervention and thinking about what is the ideal neuroprognostic strategy within the scope of what we know now and what we can potentially move into the future.
I could just reply to that, and thank you for the comment. And we have always tried in the TTM and the TTM2 trial to postpone prognostication and delay prognostication and withdrawal of care as much as possible in a pragmatic sense, and also to report in a very detailed fashion exactly how we did it, and to be able to compare the two different intervention arms, but also to do a lot of neuroprognostication studies on the patient cohorts. But I agree with you, Sarah. It would be fantastic to do a real neuroprognostication study where we used all the different methods that we have available to see which combinations are really the best ones to prognosticate. That will take a lot of money and a lot of funding, and I'm not sure that it's a sexy enough subject to get those funds for, but let's try it. I think it will be very important. And for the TTM trial, I would say by cons, wait and see.
All right, well, thank you so much to our debaters and to all of our panelists and all of you for joining us. This was a great discussion, and thanks also to my co-chair, Fabio Tacconi, and enjoy the rest of the day, and we'll see you later. Bye-bye.
Bye-bye. Bye-bye.
Thank you.